sensitivity of ablation.
Thank you, Andrea. Thank you again, DJ and KCHRS. It's a pleasure to be here. So this is kind of nice. We see this when we ablate AFib. We see this dissociated electrogram. We like it because it tells us we have acute success. But do we really need this? I mean, is it important? I mean, who really cares, right? When you think about it, why don't we just draw some big circles and not worry about this? I'm seeing Andrea looking at me with a puzzled look, about to fire me from my job. So this is an interesting study. This is an outrageous kind of study where they did that. So this is called the Avatar AFib study. And it's interesting because they had 3 arms. One arm, they did this Avatar protocol where they just did a balloon in the pulmonary vein, ablated, didn't look at electrograms at all. They didn't care what the electrograms showed. They didn't even look. The second arm of the study was antiarrhythmic drug therapy, and the third arm of the study was conventional ablation, where they did actually look at the electrograms. They cared about whether the electrograms showed block or not. When they did put the balloon in, they wanted to make sure they had a decent seal on the balloon, but that was about it. No signals were recorded whatsoever. And here are the results. So if you ablated, whether you did the Avatar protocol or the standard protocol, you were better than the antiarrhythmic drugs. But also importantly, if you didn't look at electrograms or you did look at electrograms, it was the same. It didn't matter. So are they important? Who knows? What about pulse field ablation? That's where we're headed. It looks like pulse field ablation may take things over. We have to remember that the electrical effect with pulse field is significantly more than the cellular effect with pulse field, meaning you lose electrograms when you ablate much faster than you actually get rid of tissue. And so that makes our paradigm of how we think about electrograms a little different, because it may mean that you can't tell when you're done or when you've actually achieved what you want to achieve. Take a look at the top. Right under the EKG, there's the electrograms, and there we deliver pulse field, and the electrograms all disappear. Does that mean we're done? Does that mean that we have now accomplished everything we need to? So the electrograms are important, but how important are they going to be as we move forward in our field? Well, I would argue that they're still very important. This is a couple of examples. This is a nice atypical flutter, and you really don't even need a mapping system when you have an electrogram that's that long and fractionated, and as soon as you deliver RF there, it terminates. A couple of things to note about that electrogram is it's very small, it's very fractionated. This is the kind of thing you have to kind of look for. It's not easy to find this sometimes. You can just swing by this and think it's noise. It's very small. Here's another example of ventricular tachykardioelectrogram. Again, note how small this electrogram is. So electrograms are essential for our field, but our field is complex. We have advanced mapping systems, we have multi-electrode catheters, we have small signals of interest, and there's a lot of signal-to-noise issues that occur in the EP lab. What's the ideal EGM? What do we need from our mapping systems? What do we need from our recording systems? We need a signal-to-noise ratio that's high. We need a lot of signal, very little noise. We need no signal loss or saturation when we pace or when we cardiovert. We need to detect far field from near field, and we need insight into tissue therapy. This is an example of actually a far field recording. See that isolated signal? That's actually the right upper pulmonary vein being recorded from the superior vena cava. I don't know any system that can tell me that's far field. That's a hard one because it's so sharp. But just an example of the challenges that we face with this. Here's another example. You see this little electrogram of significance there. That's exactly the right place to ablate, but it's so small, and after you pace, it sort of disappears. These are some of the sources of noise in the EP lab. You have the recording system, amplifier, stimulator, catheter, RF ablation, fluoroscopy, the table, all of these electrical devices, hemodynamic monitoring, temperature regulator, all of these things. Our EP lab, which has a separate ground from the whole hospital, still has occasional issues with noise, and so this is still an issue all around the country. Part of the problem is how we traditionally acquire our signals and how we traditionally filter our signals. So on the top, you can see this is sort of the traditional way to do things. You have an amplifier, another amplifier, high pass filter, low pass filter, notch filter, another amplifier, and then an A to D converter at the end. And so there are new ways to do this, and there's a couple of different technologies that are looking at this, and we'll highlight one particular technology called the pure EP system, where it's a whole different way of thinking about the electrogram. So it's signal preconditioning, fixed gain, and an A to D converter. So it changes a little bit how we can acquire our signals. And just to give you an example, you can see side by side on the left is the GE signal, where you really can't see the electrograms, whereas on the right you can actually see some electrograms with the newer, more advanced sort of pure EP way of doing things. We took a look at this a few years ago. This is a paper that we published in JCE, where we took signals during ablation procedures. We took signals that were small, we took signals that were significant, we took signals after pacing, after cardioversion, or signals where tachycardia is terminated, and we time-stamped those signals. Then we took a look at the pure EP signal versus the GE signal, and we optimized both of them. We randomized them, we scrambled them up, and we gave them in no particular order to several outside reviewers who then were to grade which signal was clearer, which signal was better. Here's a couple of examples. You can see on the pure side, again to the left in this case, much better signals on the lasso electrogram and on the ablation electrogram. Again here, another case, this is a ventricular tachycardia case, the quality of the signal is better. And then here's another case that kind of shows clear-cut hiss where you wouldn't see one in the GE system. And when we did this and we gave this to our reviewers, the reviewers, by and large, about 80% of the time said the newer way of doing things was superior to the older way of doing things. And in fact, it was only inferior 7% of the time. So the vast majority of the time is either equivalent, more than 90% of the time, equivalent or superior. And not only that, we had consensus in just about all of the electrograms, with the exception of 7% of the electrograms, there was non-consensus. So people agreed that this was definitely a better way to look at things. And again, like I said, we looked at things like near field versus far field, small fractionated electrograms, post-cardioversion, and so forth. So that's good. That helps us tell whether the electrograms are there and can we detect them better. But is there more insight we can squeeze out of the electrograms? So this is an interesting idea here. This is a study that was done at Cleveland Clinic. So now you're taking electrograms and you're saying maybe as we do an ablation, we can look at these electrograms and see whether there's insight into whether we've achieved transmural ablation or not. So this was a swine study. They delivered RF ablation in these swines, and they looked at the unipolar electrogram, and the unipolar electrogram should have a negative component, but as you ablate, as you deliver therapy, that negative component starts to turn more positive, and when it turns more positive, are you transmural or not? So this study sort of asked that question, and it turns out that if you turn positive and then wait about 3 seconds, you've essentially achieved transmurality. And so this is just the system that they developed, and you can kind of see here, once you start ablating, it color codes it for you. So I'll show you, once ablation goes on, you'll see a bit of noise. Okay, here's ablation on. And then once you lose that deep S wave and you start to get an R wave, it changes color. And then you wait 3 seconds, now you're transmural. And things like this can impact the amount of time we have to ablate. Same group, this is an abstract published at HRS this past year, where they tried to look at making a contiguous lesion. So they tried to ablate, and again, the same concept held, that if they could do this, lose that S wave on the unipolar electrogram, you were able to achieve transmurality with RF. Again, we haven't really solved the issue of PFA yet, but this is actually in press right now, and this will be published this month in Circulation A&E, and it's a similar sort of story where you take a look at the unipolar electrogram, deliver pulse field, and then by examining the unipolar electrogram, may be able to get a sense of where your lesion will be. And this is still early work, needs to be developed a little further. So we go old school, or do we go next generation? I guess that's my question. Old school, poor signal-to-noise ratio, old school filters, signal washout, and EGM only. Next generation, improved signal-to-noise ratio, improved filters, no signal washout, and some understanding of what's going on under the signal. Are we getting success with our ablation? Still have a few considerations. What do we do about PFA, and how do we incorporate this into a workflow that makes sense? So conclude here, EGM may not always be necessary, and as we go into the world of PFA, we'll have to understand this a little bit better. However, for everything else, it's fairly critical. Leveraging sort of our new filtration, amplification, can lead to better outcomes, better signal identification for critical areas, and potentially better therapy as well. And thank you.
Our next speaker is